How to interpret a 12-lead ECG for SRNAs and CRNAs, DMP project by Nicole Tracy and Jillian Berg. Electrocardiographic interpretation is utilized across the entire perioperative period. Often ECG changes are one of the first indications of cardiac compromise, making it essential that SRNAs and CRNAs are able to recognize and treat these changes. A 12-lead ECG gives us multiple views of the heart's electrical activity from different angles. Each lead is essentially a camera looking at the heart from a different direction, showing the same electrical activity from different perspectives. The 12 leads include 4 limb leads and 6 precordial or chest leads. The limb leads produce leads 1, 2, 3, AVR, AVL, and AVF on the ECG. Lead 1 shows the view of the left ventricle's high lateral wall. Lead 2 and 3 show the heart's inferior wall. Lead 2 most closely aligns with the heart's normal electrical direction. The chest leads, V1 through V6, view the heart in the horizontal or transverse plane, providing a different perspective of the heart. A simple rule to remember is that when electrical activity moves towards a positive lead, the waveform deflects upward. When it moves away from the lead, the waveform deflects downward. This helps explain why ECG waveforms look different across leads. The transition zone is the point in the chest leads, V1 through V6, where the QRS complex changes from mostly negative to mostly positive. Normally, there is a gradual progression. V1 through V2 are mostly negative, V3 to V4 become more balanced, and V5 through V6 are mostly positive. The transition occurs where the QRS is roughly equal above and below the isoelectric baseline. This usually occurs around V3 to V4. Delayed transition occurs with left ventricular hypertrophy, and early transition occurs with right ventricular hypertrophy. Before we start interpreting, it is important to understand the basics of the ECG paper. The standard speed of the paper is 25 millimeters per second. Each small box represents 0.04 seconds, and each large box represents 0.2 seconds. The full ECG is 12 seconds long. These measurements are what we use to calculate intervals in heart rate. To keep ECG interpretation simple and consistent, we'll use the same step-by-step approach every time. Let's first look at how to calculate the heart rate. For a regular rhythm, you can use the 300 rule by dividing 300 by the number of large boxes between R waves. For slower or irregular rhythms, count the number of QRS complexes across a 10-second strip and multiply by 6. Of note, many tachyarrhythmias present with heart rates around 150. Next, determine the rhythm to be regular or irregular. A regular rhythm means there is consistent spacing between each QRS complex. In a normal ECG, there should be one P wave before every QRS complex, indicating that the impulse originates in the SA node. The PR interval, measured from the beginning of the P wave to the first deflection of the QRS complex, is about 3 to 5 small boxes. A normal QRS duration is less than 3 small boxes, indicating normal conduction through the ventricles. A normal QT interval is about 2 to 3 large boxes. Prolongation beyond this range may increase the risk of arrhythmias. A good rule of thumb is that a normal QT is less than half the preceding R to R interval. In a normal ECG, the ST segment should be flat or isoelectric. The T wave should be smooth and upright in most leads. Using a consistent step-by-step approach allows you to quickly identify a normal ECG and recognize abnormalities when they occur. If any of these components fall outside of normal ranges, the ECG may be abnormal. Now we are going to go over some of these common abnormalities that we may see perioperatively that may prompt further evaluation. Electrolyte imbalances are a common and important cause of ECG changes in the perioperative setting due to the patient's NPO status and fluid changes. Hyperkalemia is the most dangerous electrolyte abnormality that can occur, making immediate recognition vital. Hyperkalemia can cause tall and peaked T waves, widened QRS complexes, P wave flattening, prolonged PR interval, and eventually sine wave patterns, which is when the P wave gets lost and the QRS complex gets broader. Patients with chronic kidney disease, end-stage renal disease, acidosis, or patients who are hypoventilated or have had massive blood transfusion are at high risk for hyperkalemia. Hypokalemia, on the other hand, may present with flattened or inverted T waves, ST depression, and prominent U wave. Patients who are experiencing GI losses, have poor nutrition, are on diuretics, or are alkalotic or hyperventilated are at higher risk for hypokalemia. Calcium abnormalities affect the QT interval. Hypocalcemia causes QTC prolongation primarily by prolonging the ST segment, and hypercalcemia does the opposite. A prolonged QT puts patients at risk for syncope, seizures, or sudden cardiac death secondary to torsades. We especially need to monitor for these potassium and calcium electrolyte changes in patients undergoing renal surgery, those with chronic kidney disease, patients on diuretics, or those experiencing large fluid shifts or requiring massive transfusion therapy. Many anesthetic drugs affect the ECG, particularly by prolonging the QT interval. Many commonly used anesthetics prolong the QTC, while others are considered to have less of an effect on repolarization. Drugs that are known to prolong it include isoflurane, desflurane, succinylcholine, neostigmine, glycopyrrolate, and antiemetics like ondansetron and Haldol. Safe alternatives with less risk for QT prolongation include sevoflurane, non-depolarizing neuromuscular blockers, and sugammadex. Overall, these effects are especially important in patients with baseline prolonged QT or other cardiac risk factors, where careful drug selection and ECG monitoring are essential. ST elevation or depression is one of the most critical findings we can identify on an ECG, as it may indicate myocardial ischemia. The location of ST elevation helps us determine which area of the heart is affected. ST elevation is most often accompanied by reciprocal changes in the opposite leads. This diagram is a helpful visual reminder for memorizing which leads will show ST elevations for each different MI location. Elevation in leads 2, 3, and AVF, with reciprocal changes in 1, AVL, V2, and V3, suggest an inferior wall myocardial infarction. Elevation in V1 through V4 with reciprocal changes in leads 3 and AVF indicates an anterior wall infarction. Elevation in leads 1, AVL, V5, and V6 with reciprocal changes in V1 and V2 corresponds to a lateral wall infarction. Recognizing these patterns perioperatively allows for rapid diagnosis and management of myocardial ischemia. One important ECG characteristic that often mimics an acute myocardial infarction is called early repolarization. It is a normal variant that is often seen in young athletes. It is synonymous with the J-point elevation, or elevation of the point where the QRS usually meets the isoelectric line. Elevation in this case should be concave and greatest in the precordial leads. Remember it by this photo where the top image represents early repolarization, which is a happy, benign finding. The bottom photo represents myocardial ischemia. Being able to differentiate between the two will put your mind at ease. In this example here, when looking at some of the precordial leads, we can see concave J-point elevation, which indicates benign early repolarization. Atrial fibrillation, which presents with no discernible P waves, results in a loss of atrial kick, decreasing cardiac output by up to 20%. It also puts patients at an increased risk of thromboembolism due to the fact that the atria are quivering rather than beating, which causes blood to pool instead of pump. Pre-existing atrial fibrillation that is rate-controlled and hemodynamically stable is often tolerated during surgery. However, it is important to remember that the loss of atrial contraction comes with a decreased cardiac output and increased stroke risk, especially if anticoagulation has been held for more than 48 hours. For new onset atrial fibrillation, the CRNA should first assess for reversible causes such as fluid shifts, electrolyte imbalances, hypoxia, pain, or surgical stress, and correct them when possible. If the patient remains stable, management may involve monitoring, cardiology consultation, and deciding between rate control, rhythm control, and anticoagulation strategies. If atrial fibrillation occurs with rapid ventricular response, treatment may focus on rate control using beta blockers, calcium channels, or digoxin, and rhythm control with antiarrhythmic medications or synchronized cardioversion. Ultimately, management depends on the patient's hemodynamic stability and overall clinical condition. In this 12-lead example, there are no discernible P waves, and the QRS complexes are irregularly irregular. Under normal circumstances, depolarization of the ventricles takes up to 0.1 seconds. Dilation of the ventricles may cause a slight lengthening of the QRS. A significantly prolonged QRS duration of greater than or equal to 0.12 seconds, however, indicates that either the left or right bundle branch is blocked. In a left bundle branch block, the normal direction of septal depolarization is reversed, becoming right to left as the impulse spreads first to the right ventricle via the right bundle branch and then to the left ventricle via the septum. Criteria for left bundle branch block includes QRS duration of greater than 120 milliseconds, dominant S wave in V1, broad monophasic R wave in lateral leads 1, AVL, V5, and V6, absence of Q waves in lateral leads 1, V5, and V6, and a prolonged R wave peak time greater than 60 milliseconds in left precordial leads V5 through V6. A left bundle branch block is always pathological and sometimes can be indicative of an acute MI. A right bundle branch block is caused by a block at the inception of the right bundle branch. Diagnostic criteria includes the following: QRS complex greater than 0.12 seconds, slurred S waves in leads 1 and V6, and positive complexes in lead V1. A right bundle branch block can be concerning in a patient who has had heart failures or who has sustained an MI. Another reason for a broad QRS complex is Wolff-Parkinson-White syndrome, in which a delta wave is added at the beginning of the QRS complex. A patient with Wolff-Parkinson-White can go into a rapid AFib. When looking for this dangerous rhythm, think FBI as in fast, broad, and irregular. As anesthesia providers, ECG interpretation is not limited to one phase of care. We use it preoperatively to establish a baseline, intraoperatively for continuous monitoring, and postoperatively to detect complications like ischemia or arrhythmias. If there's ever a question whether or not to order a 12-lead, you should always be safe and order it. Never make a big decision based on a 5-lead ECG. A preoperative 12-lead ECG is not required for every patient. It is typically obtained in patients with known cardiovascular disease, including coronary artery disease, arrhythmias like atrial fibrillation, heart failure, or prior myocardial infarction. It is also indicated in patients with active signs of ischemia and when the heart rate is not within limitations for the age range. In addition, a 12-lead is recommended for patients undergoing intermediate to high-risk surgeries, such as cardiac, vascular, thoracic, or major abdominal procedures. In the operating room, we typically use 3 or 5-lead ECG monitoring. Many monitors used in the operating rooms can display multiple leads and even simulate a 12-lead view when a concern presents itself. However, CRNAs must advocate for obtaining a full 12-lead ECG if significant or new ST segment changes, conduction abnormalities, or concerning rhythm changes are detected, as this provides a more complete assessment of myocardial ischemia or cardiac pathology. A postoperative ECG should be obtained if there were any intraoperative concerns such as ST changes, arrhythmias, or hemodynamic instability. It is also indicated if the patient develops symptoms like chest pain, shortness of breath, or altered mental status in the recovery period, or in high-risk patients, especially those with cardiac history or undergoing major surgery. Many perioperative cardiac events, including ischemia, infarction, and arrhythmias, occur minutes to hours after surgery, making early postoperative ECG monitoring critical. ECG monitoring should be targeted and guided by clinical content rather than routine. You do not need to obtain a preoperative 12-lead ECG for routine cases in young patients, someone with a history of benign arrhythmias, and asymptomatic patients with good exercise tolerance. A 12-lead ECG is also not indicated for healthy patients undergoing low-risk surgery when there is no suspicion of ischemia or arrhythmias, and when artifacts are present without clinical correlation, like vital sign changes and/or signs of poor perfusion. In anesthesia, ECG changes are often the first sign of a problem. Early recognition of ischemia, arrhythmias, or electrolyte disturbances allows us to intervene quickly and prevent serious complications. Thank you.